Well, good afternoon. Let's get started. I'm Brenda Metzler, a community and program support specialist with Let's Grow Kids, and I am happy to host this month's conversation with health professionals from the Vermont Department of Health and the Vermont chapter of the American Academy of Pediatrics. I expect they're going to help us better understand some of the CDC's risk levels and Vermont's statewide approach to those that guidance. They're going to remind us what steps to take if we need to report outbreaks. They're going to fill us in on the current status of the vaccine rollout, and I'm sure they have more, including some of the questions that you submitted when you registered. So I'm happy to hand it over to the health professionals. Thanks for joining us.
Hello, everybody. Thank you for having us today. These meetings are such a great opportunity to connect with you guys, and we want to acknowledge that the move from rapidly changing guidelines to this period with less guidance can be really challenging. I know at times that Molly and I look at each other and ask, are we missing something here? So it can be really confusing. And it's a shift from going to go from extremely detailed regulations to making your own guidance, especially trying to navigate this while caring for children who always seem to have some sort of symptom. We also want to thank you for all you're doing and again offer our support. So please reach out with questions or concerns. We're hopeful as we move through and out of this pandemic that we'll soon be able to shift from some other topics of interest to you during this webinar. Last time we were here, someone suggested reviewing the updated CDC milestones, which we are very excited to do. And if there are any other suggestions for future topics, please drop those in the chat. So today, we're going to start off by having our other panelists introduce themselves and give a brief update on what's happening in their world. If you have any questions, please, again, put those in the Q&A box and we'll address them during that Q&A portion of today. After the introductions, we'll review a sample childcare illness policy, as well as providing an update on the testing access for childcare programs. So we've got some exciting stuff to review, and then we will conclude with questions from the field. So Becca, do you want to just give a little update from your world right now?
Yeah, sure. Hi, everyone. I'm Becker Bell. I'm a pediatric ICU doctor at UVM Children's Hospital in Burlington. And I'm the current president of the Vermont chapter of the American Academy of Pediatrics. And I can say what we've been seeing in the hospital in terms of both hospital admissions, kids getting admitted to the hospital or the pediatric ICU is really reflective of what we're seeing in the community and what you're seeing in terms of some non-COVID illness. So we haven't had a child admitted for a COVID-related illness to the hospital, even the floor, since I think February maybe. Every day I met a child with respiratory distress related to other viral illnesses. So we do a lot of testing in the hospital, so we actually can put names to the viruses. So throughout the pandemic, we've seen a lot of rhinovirus, and we continue to see it just at the normal rates that we would see pre-pandemic. Respiratory syncytial virus, we're seeing a bit more of than we did the last couple of months, but still lower than we normally would pre-pandemic. Same with influenza. I've had a few cases, but we never had a big influenza, December, January. Usually we see a lot of influenza. We did not this winter, thankfully. And then a few other viruses, metapneumovirus that we see also very common. So essentially what we're seeing in the hospital now is pretty typical for what we would see in March and April in a normal pre-pandemic year. There is lots of COVID in the community, as you know. We don't really know how much, which we can talk about, but we're not seeing it reflected in kids, at least kids getting hospitalized for it. So that's helpful. The GI, there's a lot of gastroenteritis going around that my colleagues in primary care are seeing a lot of, but it's not rising to the level of needing to be hospitalized. But that's something we typically do see in the spring, generally pre-pandemic. But it seems like we're all of us are getting back used to what it was like before the pandemic, either having our own children, working with children who have these illnesses, and that is unfortunately we get sick once or twice a month. So we're kind of back in that role and sort of thinking about how we can encourage good health hygiene habits going forward. What did we learn from the pandemic that we can take with us and try to limit some of we're not going to be able to get rid of it completely, but limit some of these infections in our homes and our workplaces and childcare and school and stuff. So we're trying to learn from what we know from the pandemic. And I'm happy to be here. And I also just want to, like always, thank you all for everything you've done.
I think we had Monica on for next. I think
We can't hear you, Monica. We still can't hear you.
Well, why don't should we maybe move on to Allison and John and then loop back to Monica?
Let's see, she's connecting. So my name's John Davey. I'm a health surveillance epidemiologist here in infectious diseases at the Vermont Department of Health, and I am coordinating our COVID-19 epidemiological work. As you can, as everyone knows, I've been here since January, and it's been exciting. Kind of as we transition into whatever we're going to call the post-pandemic world. As folks are aware, we've seen cases ticking back up a bit, but as Dr. Bell highlighted for him, we have not seen this, resurgent demands on our healthcare system. Hospitalizations are still looking, COVID-like hospitalizations are still looking comfortably lower than they were before last winter. So a lot of what we're trying to do, and a lot of what I think we're going to hopefully all work together on, is what is respiratory illness going to look like in a post-COVID pandemic world, and how can we leverage what we've learned from COVID, resources we have from COVID, to be able to keep our kids, our teachers, our communities healthier and safer. We know we're not going to be ever at a zero COVID world, but we know we've got a lot of tools to reduce serious illness. And as a department, we are available to assist facilities in dealing with outbreaks, with just situations of concern. And this is a really distinct population. Obviously, we don't have the vaccines for the youngest kids yet. Our testing strategies are, there's some real exciting stuff going on with testing right now, but also in this population, the at-home antigen and LAMP tests aren't for use in the under 2-year-olds. So this is a challenging and interesting sector, but it's also one where we've got a lot of tools and where we're really excited to work together and help facilities that you work with kind of develop a real good layered approach to minimize the impact of COVID in their facilities and in their communities. So thanks.
Allison, I don't know if you feel like you want to add anything or.
Yeah, I'm Allison Lafferty, and I'm with I have a dual role now with the Epi-COVID team and also a separate role with the STI team, actually. But I don't need to add anything to what John said. I think he encapsulated what the COVID team is doing wonderfully.
Okay, so let's try Monica again.
All right, take 2. Yay, okay. When I called in, it only admitted me as a attendee, so I think that's the problem. Sorry about that. My name is Monica Ogilvie. I'm a pediatric nurse, and I'm the immunization program manager over at the health department. I started in September, and so most of my work has been largely related in COVID vaccine and everything COVID. And I'm here today really to talk a little bit about what the future planning looks like for vaccine, especially as we think about vaccine for kids that are in the age group that are attending childcare and in childcare settings, which is really exciting to think about as a tool and as a resource to keep our communities healthy. So I'm really just here as a resource to answer your questions and to think through how we can support you and the families that you're caring for. We are very, very fortunate that we have such committed, engaged pediatric healthcare providers throughout the state who have done an incredible amount of work in thinking, planning, and preparing for administering vaccine to this next age group. So for those of you that have been vaccinated yourself or have maybe kids that have been getting vaccinated, historically, Vermont has had these sort of large-scale mass vaccination clinics. You go onto the health department portal, you make an appointment, And all of that has changed. And that's for a variety of reasons. Number one, the demand has definitely declined, and that's to be expected. But the other real reason why our approach for vaccinating this next age group, which are kids between 6 months and 4 years of age, is because that type of mass vax or community clinic setting might not necessarily be the most appropriate for them. And we know that these kids are already getting a lot of vaccines in this age group. They're already seeing their primary care pretty regularly. And so they probably have a lot of questions about what it's going to look like, how do they integrate this vaccine into the routine vaccine schedule. And so we really wanted to facilitate opportunities for families to have conversations with the healthcare providers that they trust. So we're now in a space where we anticipate that these children in this age group are largely going to get vaccinated in their primary care offices. And just to give you a sense of what our coverage looks like throughout the state of Vermont, because again, our pediatric healthcare providers are absolute rock stars. Almost every single office that cares for a kid between the age of 6 months and 4 years old is going to have vaccine in their office right out the gate. Doesn't mean they're going to be able to vaccinate all their kids in this age group right out the gate, but we don't expect the demand to be there anyway. So we do think that it's going to be a little bit more of a slow and steady approach, that kids and families are more likely to get vaccinated as they see their provider in their routine schedule. And we're just eternally grateful for all that you've done, especially since these itty bitty kids are the last ones to get vaccinated, and that just creates a whole layer of complication and grief and anxiety for a lot of people. And as a parent of a child in a child care center right now, I am eternally grateful for your mere existence every single day. So happy to be here.
All right, so thank you, everyone. And I'm going to start by going over the sample illness policy. So we had a number of questions about how we can create an illness policy in the time of COVID. So Katie and I were lucky enough to work with Dr. Bell in the Vermont chapter of the AAP and wanted to share with you an example of what an illness policy could look like. And we really want to emphasize that this is a sample policy. It's not something that people are required to follow, but it offers an avenue to safely keep kids in care using Vermont Department of Health guidelines. So we're going to talk through the policy right now, but we do also want to just let you know that it's going to be sent out soon. We're just finalizing a few pieces of it. So the basis of this plan is to use the pre-existing childcare and out of school care regulations, but adding in the use of testing to differentiate between COVID and other childhood illnesses. We still want sick kids to stay home. That message isn't changing at all. But when a child develops a runny nose while in care, testing would allow the mildly symptomatic child to remain safely in care rather than needing to send them home. So if a child partway through the day becomes symptomatic and those symptoms make them fall under the exclusion guidelines in the child care regulations, your usual process of contacting the parent or caregiver and sending them home would be followed. That's still in place. Where it differentiates is that if they would not normally be excluded from care per the regulations, that's when we would look to testing. And this testing would be using rapid antigen tests on children over the age of 2. So if you test the child who's over the age of 2 and the antigen test is positive, you would send the child home and direct the family to follow Vermont Department of Health isolation guidance. If the antigen test is negative, however, that would allow the child to stay in care. And we would also recommend sending the second test home with the family to test again the next morning prior to arriving to care. And we want to just acknowledge there's a known limitation here. Antigen tests aren't approved for children under the age of 2. So for children under the age of 2, our recommendation would be sending them home if they have new onset symptoms. We would recommend that they get a COVID-19 PCR test. And this is a recommendation. It is not a requirement. And I know there can be some confusion with LAMP tests, as they're often called rapid PCR tests. LAMP tests are not approved for this age group, so it would have to be a true PCR test for them to be cleared. And if a family chooses not to test their child, regardless of age, the child can return when their symptoms have improved and in accordance with childcare licensing regulations. And we do want to just address the LAMP test for a moment for children over the age of 2, as they tend to be a little more sensitive. We feel a little more confident with their results. So if a child has mild symptoms prior to arriving at care and the family has access to a LAMP test, we would support them being allowed in care that day as long as they obtain a negative LAMP test prior to care. And yeah, so that's the big overview of it.
Okay, thank you, Molly. So she went over the basics of the sample policy. And so the recommendations in the sample policy are really dependent on access to tests, as we know. So we want to share with you some updates regarding childcare testing access. So just to reinforce one really important piece of this is a voluntary option. It is something that you may choose to implement at your childcare. We are currently working with the CDD to ensure that access to antigen tests is available for all childcare programs for the purpose of allowing children with minor symptoms that are not COVID to remain in care after a negative test. Additionally, if a child stays home sick, their family would be able to access antigen tests from the childcare because we know that sometimes transportation or access to those Department of Health ones might be difficult for a family. So while some of the details are still being worked out around the test access piece, here's what we do know. So there will be an online portal to sign up and order tests, and the ordering process will be very similar to the ordering process that you already know from Test for Tots. Again, this program is not Test for Tots, but the ordering piece of it will be similar. Unlike Test for Tots, there are not program requirements you must follow. The ordering process is the only similar thing to Test for Tots. Everything else is voluntary in how you choose to implement it. We will only be providing antigen tests. These tests are intended to be used with children aged 2 to 5. And then staff members are encouraged to obtain tests from the state of Vermont testing sites. So the goal of this testing access program is really to keep, again, those mildly symptomatic children in care on the day, so that you have that assurance of the negative antigen test. So once the details are finalized, the CDD will be sending out more information. We're anticipating very early next week, but that depends on some logistics, including moving large amounts of tests to the warehouse. And the plan is that the tests will be shipped directly to the childcares.
All right, so we are going to move into questions from the field. So the first question is asking if it's true that the illness exclusion rules outlined in the child care licensing regulations, Appendix A, are essentially the bare minimum. For example, the regs state that a child with a fever does not have to be excluded unless various other symptoms are present. But if I wanted my program policy to state that children do go home to monitor at the onset of a fever, families should not be able to use the regulations saying no to fever exclusion as a way to argue my policy. So it is correct that the child care and after-school licensing regulations are foundational requirements. As such, child care and after-school programs may create stricter standards for their programs. But programs are encouraged to work with a healthcare consultant to make sure that the policies we're creating are informed and are balancing health and safety while meeting childcare needs. And it's important also to note that a program is required to have an equitably applied policy for all children and families. And again, throughout it all, we want to emphasize we still want sick kids to stay home.
It's on mute. All right, next question. Is it possible that the VDH could create some sort of communication between the early childhood programs and doctors that is more than a generic child can return to school note? Something with more information, such as a diagnosis, a treatment, contagious period, timeline for recovery, etc., that we could use to inform our decisions of when children are ready to return to school. If this isn't possible, would it be asking too much if programs made a form of their own for families to give their physicians at sick visits? So this is not something that the Department of Health would be responsible for creating. Child care could create something on their own, however. But you want to keep in mind, a communication tool will likely be difficult to implement with the medical providers. The increased paperwork and the level of detail suggested in this question might be very difficult to achieve. Also, there could be some barriers in the form of a HIPAA and confidentiality for the child. The best practice that we would recommend, the ideal, would be local communities developing communication pathways between the child care and pediatric medical homes to increase that understanding and like the shared approach around caring for the child. But I thought maybe this would be a good time for Becca to weigh in if you have any thoughts on this.
Yeah, I'll say from my primary care colleagues and, also similarly, when you look at the caring for children policy, it does say that most illnesses, even if children shouldn't go to school or shouldn't go to childcare, they don't necessarily need to see a medical provider for that. And we can imagine that situation, right? Like a kid has a runny nose and a cough and they're napping extra and they really shouldn't be in childcare, but you wouldn't really need to bring them to see a medical provider. And so we want to avoid creating a system where people end up feeling like they have to see a medical provider when they normally wouldn't, just to get a note. And that has happened in the past. And, we try to do that. My colleagues who take care of adults sometimes employers require work notes. And that's, again, it's a silly thing to have someone who's not feeling well come into an office and just really for a note. When I used to do ER shifts, when I was a trainee and I did the overnight shift, every weekday between 5 and 7 a.m., I would usually get 1 or 2 families that were coming to the ER to get a note to say their child was well enough to go to childcare. So that's the kind of thing we want to avoid, right? Like I'm here in the emergency department because I have to work and my child's fine, but I need a note. So we want to avoid that kind of thing. This isn't really what you all asked or really asking about, but I am so impressed sometimes by some of the very medically complex children I care for in the ICU who attend childcare regularly. And I know that you care for really medically complex children. And so that's where I think having really good communication with the medical home, with the family, making plans for really specific plans that are really individualized for that child is really important. And again, I'm always so impressed by you all and the care that you provide for some of our children in our community that are really, really have a lot of medical needs. But yeah, we're trying not to create a system where there's extra visits that wouldn't normally happen.
All right. The next question is, if we're saying that all sick people stay home, should we also be recommending that all sick people see their physician? Is that what helps us alleviate the massive amount of gray area between what a family sees and understands about their child's symptoms and when childcare providers believe a child is ready to return to school? And so I know Becca just kind of addressed this a bit, but if someone's sick, I think it's okay to call their primary care provider and discuss symptoms. And the medical provider, an individual or parent can then decide together if the child needs to be seen in the office. I mean, if you think about an illness like a stomach bug, the medical provider can counsel over the phone, suggest symptoms that would indicate a worsening condition or reason the child needs to be seen in the office. But if the symptoms are resolved in 24 to 48 hours, the sick person likely wouldn't need to be seen. So it's really, making a call, consulting with the provider, but being seen in the office itself is not a requirement for every sick person.
Okay.
And I was just going to say, I sent Brenda the sample policy that we had drafted just so that she can share it on the screen, as Becca pointed out nicely for the visual learners out there. So I think Brenda was going to share that policy, and then we can go to any other questions that are in the chat.
So I queued it up beautifully and now I can't find it. It'll take just a moment.
Well, while you look at that, I just see one question in the chat real quick. So I think it's somewhat related to this policy, so it's not bad if we have it up at the same time. So the question is, could you please define minor symptoms? I think this is the place where so many programs are struggling and also where there are significant gaps in our approaches. this becomes confusing for families and also frustrating. And I mean, I agree. I think this is something that we have grappled with, I think the entire pandemic, and any time that we're trying to draft something, it becomes a question of what is mild symptoms and how are we supposed to define this in a way that can be universally approached. And it's a struggle. And so what we did when we thought about this was thinking about mild symptoms in the way that it was approached in caring for our children. In your exclusion chart, it lists a bunch of symptoms that kids will have. And with each of those symptoms, it generally it would say, like, you know, they don't need to be excluded unless this is going on with the symptom. So we would generally say if they're not meeting exclusion criteria, then based on the caring for our children guidelines, we would say that is likely what we would consider a mild symptom. I don't know that it's a perfect science, but it's what we could come up with as a more universal approach of saying what is our understanding of mild symptoms. I don't know if other people have more they want to add to that.
I think the caring for our children resource is helpful. It gets a little bit more specific as well. And I do know it's so hard to not to have that kind of gray area as people are mentioning, but we've also seen it become a real challenge when we try to get very, very specific about symptoms and days and tests and all that. So I think this is sort of kind of threading that needle here where we're moving away. We've moved away from saying like asymptomatic children have to stay home because they were close contact, right? And really thinking like we really want families to keep kids home regardless of what they have, whether it's COVID or something else, during periods where they could be infectious. So that gets challenging. So what do you do with the kid with like the post-viral cough, which lasts for another week or two? What do you do with the kid with allergies? And every case is a little bit different. And so I think looking at the caring for our children as a resource can be helpful there.
I have a question as people glance at this sample childcare sickness policy. Where will that be, when and where will that be available for programs to use?
You can go, Katie.
So basically, that's just being finalized right now. It's a couple of extra eyes looking at, over, making sure that will be, that everything is correct. And then we will be sent out to the CDD. Will be sending that out, and we'll have access to it again. And I think looking at this next question on here.
Real quick, Katie, I just want to add in that I think it's going to be when we have the official announcement about how to sign up for antigen tests and all of that, it will be done in conjunction with that, and we will have it on the website at that point as well.
Yeah, we want to make sure everything is together prior to sending it out so that you guys aren't struggling to find things.
Excellent, thank you.
And then this next question around parent permissions to administer antigen tests to their child at school. So that was a piece that is addressed in the sample policy around making sure that there's a consent form to test the child in the school. And, this is a voluntary process. So it's really meant to be a guide if you need a guide, the sample policy. And the same thing with the tests. The testing access is really just meant to be something you can access if it works for your childcare and if you feel comfortable administering them. I mean, certainly we could offer some support around, administering if needed, or you can reach out with questions. But, as far as continuing to provide tests to families and asking families to administer mild symptoms, there aren't rules attached to this access to testing, and they're not going to be monitoring your use of them. However, it really is designed to keep symptomatic children who develop symptoms while at the childcare in the childcare for the day, if possible. So parents aren't having to leave work and come back and pick up the child to go to get tests, that kind of thing. So, so that is the goal of it. And then there are going to be abilities for families to access the testing kits at the other Department of Health sites. So not to say that you can't decide to give a family a test kit for that child, or that they can, like we said before, they can come to the childcare and pick up the kit if their child needs to stay home for symptoms. That said, it's just the goal really is to keep those children who develop symptoms while in care for the day. So that's Molly.
I was just going to add with the teacher confidence / comfort around administering. The other thing to just know is on the Department of Health website on the testing page, there is information on the tests and how to use the test, how to administer them, and it's in multiple languages. So I know that doesn't necessarily, it's not a magic wand that says, oh, I'm comfortable with it now, but that is an option for people to become more comfortable with the tests and how to use them.
Yeah, and the other thing, thinking in terms of, again, the voluntary nature of this, it's really what works for your childcare program and your facility and the size of your facility, how much staff you have, all that sort of thing plays into that, because we all know every program is a little different. So.
All right, so the next question was, we had many illnesses in the program and allowed children to remain. However, today a parent and 2 staff have tested positive. So how should this be handled? And I'm going to let my EPI colleagues tackle this in a moment. But the one thing I will say is this is why we're really hoping to get you guys a lot greater access to testing, because, we are saying there's a certain level of illness that we're accepting as a safe risk. But with COVID symptoms that can sometimes be mild, we want to have them be able to test to make sure that if a kid is staying in care while mildly symptomatic, we at least have the assurance that it's not COVID so that this doesn't happen. So that would be my first instinct, but I see John, so I'll hand it over.
I was just going to say, not knowing the specifics of the situation, hesitant to give a sort of blanket guidance, but staff ideally would be away from the facility for at least 5 days since the onset of symptoms, if that's what triggered a test, or since the positive test, and then wearing a mask in the facility if possible through day 10.
I would jump in to also just remind folks of what Dr. Becker Bell says every time. We know that when kids are, if kids are sick and they can't engage in their normal ways, that they need to stay home. So I would just say let's remember our regular health practices. And if they're sick, they shouldn't be allowed to remain.
Okay, so there's one last question here. I recall a goal behind Tests for Tots was to alleviate the testing burden off of the provider, given very few, if any of us, have an in-house nurse who is properly trained. What shifted to now encouraging providers to take this on? This proposal feels very supportive of families, but not of providers. So, again, I would just think to the fact that this is voluntary and you have under no obligation to implement this. And the other piece being that, I feel like what benefits families will often benefit the providers in the sense of allowing children to stay and families to work would definitely mean happier families overall. But the other piece of it is as far as the in-house nurse who's properly trained. Like I said, Molly had mentioned that there are videos, but these are antigen tests that most of us are just administering at home on our own as well. So just kind of some of the anxiousness around performing the test, maybe, we could certainly offer more support around that too, but just kind of thinking this is a fairly simple test that a lot of us have done many times already. So I don't know that it necessarily rises to the level of needing a nurse. And it looks like Molly has something to add there.
Yeah, so I was just going to add that I think it's also important to remember what the purpose of this is. So Tests for Tots, we were testing all close contacts for long periods after, or for like 5 days after an exposure. And we're not doing that with this. This is not for close contact testing. This is not for just you're starting the day, we're testing you. This is for a child becomes symptomatic while in care. So if there's a miracle and everyone's healthy every day, you're never going to have to test. But we're not trying to have you test all the time. We're trying to say, oh, someone partway through the day got a runny nose. I want to make sure it's not COVID. We're going to test this one child this one time just to make sure. And so I think we need to remember what the purpose of that is as well. Becca?
Yeah, I think I wanted to echo that and say that we thought about this too, because we kind of made this shift with the schools, that we don't want to encourage families to drop off their students or our children sick because they know they can get a test there. We do know that there may be some aspect of that happening to be real. That could happen. We still want to keep things the same, where if your child wakes up sick in the morning, you keep them home and you don't send them. And this is really for that occasion. And where it's a kind of a long day, that throughout the day, if somebody develops symptoms, like a child or a staff member develops symptoms, and it's like, do we send them home? We would otherwise keep them here pre-COVID, right? Again, if they're like vomiting, they're going home. If they're not feeling well, they're going home. So the use case for this should be relatively small. I say that still understanding that there may be some kind of not exploitation of it, but there may be families who do say like, oh, I think I'm going to try to send my kid. And we want to try to discourage that, but we also want to provide the availability and the resources. If you have a kid or a staff member who otherwise would be staying throughout the day, normally pre-pandemic, they would normally say they have some mild symptoms and you or they want to get tested, then this is an opportunity for you to be able to do that. So we're hoping that it's not overused.
And I think the other thing to encourage families to pick up test kits and have those at home, have lots of kits that they can have access to, so that they can maybe just test their child at home. Hopefully that's really the push that we want people to hear is, test when you have symptoms and, keep a supply at home too. So really making sure they have access to that, those sites.
All right, and we had a new question come in saying, is there any sense that we should consider instituting universal masking again if we went to an optional policy recently? Could that recommendation be coming again in the coming weeks or months? Oh, well, no worries, you didn't miss it. So right now, and this goes back to the risk level. So I know there's a focus on like the CDC has the risk levels county by county. And so people will look at that and say, okay, according to that, I need to be masking. But what we've been looking at in Vermont is saying, we're a small state and a lot of us are traveling between the counties so interchangeably that it doesn't necessarily make sense to be doing it on a county-wide approach. And so we're looking at it as a state. What's our risk level as a state? And so while we are still at a low level, we're not looking at universal masking. That's something that we're looking at every week, and we can't say what's going to happen in the next weeks or months because we don't know what COVID's going to do in the next weeks or months. But that is something that if as a state, it feels important to switch to universal masking, that is something that would be communicated out. And John, tell me if I was wrong.
Yeah, no, I think that's a good point. It's not something that we want to change super quick. That being said, I'm not sure what the current numbers are from what we've seen with cases. And again, partly this is because we are still doing a lot of testing in Vermont. Wouldn't shock me if we're in medium next time we get a report out. And that's really ultimately in these settings, doesn't necessarily have to change anything. Masks, we always want masks to be part of your toolkit. And I think one of the things we've seen, as someone who immediately got a cold after my son's school's masks went off, I think we've learned from the last couple of years that this is going to make sense to have in our toolkit during respiratory illness peaks, whether it's COVID, whether it's flu, whether it's cold. We still want to be extra cautious around people who are, immunocompromised. We still want to, be mindful of the fact that our youngest ones aren't getting vaccinated yet. So I don't know that the even the move to medium, I wouldn't expect would necessarily change so much of the way we operate. We're a long way from being in the high range. What's really driven us when we've seen medium in counties, and if we see it at state level, it's really our case counts. And again, Vermont's taking COVID very seriously, and kudos to all of you, and kudos to all of us, frankly. So our hospitalization numbers are still looking good. Those indicators are still looking good. So I think we really want to move towards, let's think about this as part of our respiratory illness toolkit, rather than everyone's got to put them on, everyone's got to take them off. Let's think about context. Let's think about who's around us that we need to be extra protective for. And so some factors might come in, staffing levels. If you're pretty threadbare with your staffing, you might want to be quicker to put on masking for those who can do it. And I just want to give a quick plug to, feel free to, we have staff in our local offices. We have COVID epidemiologists who've worked a lot with other facilities and helping think through these. We've gotten a lot of folks who've worked a lot really closely with long-term care, thinking creatively about cohorting, masking, ventilation, changing spaces. So think of that as something in your toolkit, and the community levels as something to when we're all in low for a while, that'll be great. But there's going to be times where we're going to want to think about taking some of these out of our toolkit again in respiratory illness season, whether it's COVID or flu or something else. So.
Thanks, John. So another question came through. Could you repeat the resource you mentioned for supporting educators to feel more confident in administering tests? I think the biggest worry for teachers will be classroom management while adding administering tests, and this could help. Yeah,
I put that in the chat.
Okay, perfect.
I put the link.
Yeah, thank you, Molly. Yeah, and I think that the piece about the classroom management, again, I can only imagine a busy classroom, lots of kids trying to test one child. So I hear that for sure. And I think, again, just remembering, like, if it feels undoable for you and it's not going to work, then or your program, then you don't need to do it. So I think thinking in terms of that, just remembering that this is just a tool if you would like to use it.
And then there was just a comment about the positivity rate being high. And I think, again, John spoke to this about how we see those fluctuations in Vermont. And, I think he spoke to it. I think he said it well, so I'm not going to try and repeat what he said because I'll mess it up.
I was also wondering if Allison had anything to add. Allison, not to put you on the spot, but was there anything you wanted to add to the conversation?
No, somebody just asked about case counts, and we are seeing them go up, especially when we include the self-report cases, which are coming up, into the 500s. But I think our positivity rate is exactly what John said, in effect, that less people are reporting their testing. So we're not getting as many negative tests probably into the denominator. So that's also affecting our positivity rate, I believe. So I think you have to consider that when you look at that positivity rate, because home tests, people don't report negatives very often on a home test. They generally only report positives when they're going to report. So I do think that's worthwhile. And I will tell you that for the first time, I think it was last week, our home test self-report outpaced our positive test results for our PCR and antigen tests that were not self-report. So we had more of those reports than the others, which is something we expected to happen, but it happened for the first time last week. So we are getting more and more of those. So I think some of those numbers are explained in part by that. Either way, we're seeing the increase, but I think the important thing to note, as we've said many times before, all the indicators are that we're not seeing the severe disease, we're not seeing the hospitalizations, we're not seeing the ICU, so all of the serious illness we are not seeing. So although we are seeing right now an increase in case counts, I think there's still good news out there. right now. And it was kind of expected. We had it. We knew BA2 was going to give us a little surge. We knew taking off masks was going to probably bring us a little flu, a little norovirus, and a little more COVID, right? Because we were taking off masks. So we knew some of that was going to happen, but I think I don't think any of this is a surprise. I think it's all okay. I think it's gonna work itself out. And I think there's a lot of good indicators still out there that we're doing well as a state overall.
Yeah, it's a great point, Allison. We're not here trying to tell you that it's not out there, that there's not a lot of cases, but we are telling you that we've got resources to help you manage it in your settings, and that our providers are doing a great job of preventing it from getting very serious in most cases.
Thank you. I'm going to just do a quick recap of what I heard some of you saying, and remind folks that a recording of this conversation will be posted on the Let's Grow Kids website within the next few days. I also think it'll be, there will be some relevant links like what was dropped in the chat for you, so that, if you sort of aren't furiously taking notes, you can revisit this. But here's what I heard. I heard that Dr. John Davies say that that these folks are available to support you and your programs. I heard Dr. Becker Bell say your preventive practices are working. Molly said that there's a sample policy available very soon, and it will be posted. And I heard Katie say that you, as always, are remembering to work with your staff and families to tailor the health practices that work for your kids and your families and your program. And I heard somebody say that the CDD works closely with the Vermont Department of Health to establish these guidelines, and those are always the foundation from which we start. So it's really, there's so much support on this screen right now, but also just always there. And when we post the recording, we'll also just post again the contacts. But I think many folks who are on the call are already familiar with those. So were there any final thoughts? We still have 10 minutes, so woohoo. Sometimes we're like, going over, but are there any other questions from folks in the early childhood field who are on the call today, or are there any parting thoughts or other things that you would like to share with us, health professionals?
Monica, we don't hear you again.
Ah,
There you are.
it's my darn phone. Brenda, I was just going to add to your summary that vaccines for kids 6 months and up are coming too. So that's another tool in the toolbox, and we should expect that to be in Vermont come June. So keep your eyes peeled and ears to the ground. We'll be disseminating more information as we have it available.
I'll just add, as someone who, like you all, take care of kids and whatever issue is going on with them and their families. And there's a lot of, other stuff besides COVID and other infectious stuff happening. And you all are, again, like the bedrock in our community of supporting kids and their development, supporting families. What you do is so important. And, we spent today talking about illness and talking about COVID, but there's so much more to what you do. And I do see that every day when I care for families. So thank you.
I wanted to echo the thank you, but much less eloquently. But I just am so in awe of the work you guys do. And I just think, it's really difficult when there's a lot of really strict regulations about what you're supposed to do and how to be in compliance, but you at least know what you're supposed to do. And so we've gone from knowing exactly what you do in all situations to being like, yep, it's a different world right now, and you kind of have to find your way back, and it's really, really tough. And so I just want you guys to know we recognize that this is not easy, and we're so appreciative of the work you do, and we're all here to support you. So if things come up, please reach out to us.
Again, thank you for everything you do, and feel free, to reach out anytime you have questions, because we love to hear from you, and we know you need help sometimes. So
Thanks, everyone. I really appreciate it. I have one other quote from our Surgeon General, and it sounds kind of silly and almost like ridiculously obvious, but I think it helps me think of when we have to. So I was a director and an early childhood educator for 30 plus years, and when we have to, when something is emerging and we have to sort of pivot. I loved this quote from the Surgeon General: "When it's raining, we put on our raincoat. When it's not raining, we take it off." And I thought of that a number of times throughout this pandemic, like, oh, now we're doing this. Oh, now we're not. So when it's raining, put on your raincoat. And so thank you, health professionals, for sharing your expertise with us again. And thank you, early childhood educators, for taking care of our children. And hey, you get 7 minutes back in your afternoon. Have a great afternoon. Thanks, everyone.